How's it look, Stephanie? Yeah. Okay. Morning, everyone. Hope everyone's having a great morning so far. My name is Christina Yadav. I am one of the NSWACs here at Sick Kids, and I work with my colleague Cindy Strong, and we cover pediatric wounds and stomas for both inpatients and outpatients. We're really excited today to hopefully collaborate on some of the challenges in pediatric wound care, or some things that you may have seen, and hopefully dispel any myths or answer any questions in regards to wound care for children. Oh, you can't hear me? Can everybody else hear me?
Yes, yes.
Okay, just checking. All right, so this is being recorded for educational purposes. Please share with your colleagues if they were unable to attend today. We definitely would love to have as many people view the webinar to hopefully support the care for our pediatric patients. Okay, so here are some of the objectives that we're going to discuss today. Common wounds in pediatrics, principles of treating wounds in pediatrics, looking at optimal wound healing and dressing selection and appropriate comfort measures in treating pediatric wounds. Stephanie's actually going to put out a poll first, though, just to understand where everybody is from, what their discipline might be, and we'll go from there. It just helps us understand our audience a little bit better. So the first question is, please tell us what your current role is. You can just type in the discipline. And do you have any previous experience with pediatric wound care, or is this your first time and you're just looking for more support?
Just give it a few more seconds. Looks like everyone's kind of answering them, which is exciting.
Okay, so far we've got sort of 50-50. Some have experience with it and some do not. So that's great. We're hoping that this will help support you to feel more comfortable with it in the future. Please feel free to leave your questions in the chat as well, and then hopefully we'll have some time to get to them towards the end, okay?
And in terms of roles, Christina, for you to know.
Mm-hmm.
So lots of RNs from home and community care, some clinical educators from hospitals, ER and ICU. So we've got a variety in the audience today.
Okay, well, welcome everyone. Thank you. All right. All right, let's talk about some common wounds that are found in pediatrics. I mean, this is very general. It does not obviously cover everything, but what we're really trying to target here are ones that may be referred to the community or other acute care hospitals. So just looking at surgical wounds, we do have a large surgical population, and so we get a lot of incisions, either with staples, sutures, dissolvable and non-dissolvable. They don't typically require home care support. We do teach the families on how to care for them, cleanse them, and protect them. But unfortunately, sometimes they do progress into surgical site infections and do require further management for dehiscence. And this is when we put referrals out to you to help support this once they go home. So when we look at surgical site infections or dehiscence, they may require antimicrobial dressings or systemic therapy. They may require packing based on the wound depth, or perhaps negative pressure wound therapy. In regards to abscesses and fistulas, we also get a lot of pilonidal sinuses or perianal fistulas for patients with Crohn's disease. The locations of these wounds can make it very challenging for management because they can be frequently contaminated or hard to adhere dressing in those areas. And then on top of that, things that can compound it are things like hair, sweat, hormones, in our teenage population, that may make it difficult for sort of compliance for dressings and as well adherence for these dressings. We do get a lot of stoma sites, so tracheostomies, G-tubes, and ostomies. Our goal is always to protect the peristomal skin. And then we're looking at managing drainage and hypergranulation tissue when there is a lot of leakage from these areas. We do use a lot of foam dressings. We'll talk about sort of the dressings that are more widely used in our area. But sometimes when we have leaky tubes and drains, we're not able necessarily to put a dressing on, and then we sort of go into sort of zinc oxide based creams, perhaps some topical powders, depending on the severity of the injury. Some congenital defects that we may refer out into the community are omphalocele. I'm not sure if anybody is familiar with these, but it is an abdominal wall defect requiring dressing changes, sometimes up until a year or more of age. It is where the organs are on the outside of the body and they're protected by a sac, and we need the skin to grow over that sac to protect the integrity of that area. So they require dressings for preventative maintenance, reducing infection risks, allowing stability of the defect is something that we're always constantly reassessing because these defects can be quite heavy. So as they start to crawl, as they start to walk, we have to think about how are we going to secure these dressings to support the developmental care. Sacrococcygeal teratomas are incisions that are typically close to the perianal area, so they can also be challenging because they can be contaminated. So we're looking at protecting that incisional integrity from that contamination and moisture. We may use, again, a combination of barrier ointments or creams, or perhaps some foam dressings if applicable. Pressure injuries, contrary to popular belief, they do happen in children. They can be caused by medical devices, and the National Pressure Injury Advisory Panel says that medical devices is the #1 cause of pressure injuries in children. And sometimes we don't see it until these things are removed. I wouldn't say that necessarily they're still ongoing once we refer them out to the community, but sometimes we do get a lot of referrals for patients who are immobile or very complex care. Where they may have tubes or drains or issues with their wheelchair, and then they will get sort of like coccygeal pressure injuries or sacral ulcers that may require further management. We do use a lot of foam dressings for padding. We find it very easy to apply on the skin and easy to remove. And then we use things such as positioners, wedges to reduce friction and support offloading. In terms of dermatological wounds, there are quite a bit that I could not cover here, and I am not the expert in these. We have a very well-versed dermatology team that helps with some of our most complex patients, but I did want to highlight some of our EB patients, our epidermolysis bullosa. As it is a lifelong disease, they are followed specifically by our dermatology team with specific guidelines on dressing management, and it's very specific for a reason, because we want to ensure that what we're putting on the patient is not causing trauma to the skin. EB is characterized by fragile and blistering skin. It can be further compounded by heat, friction, and adhesives. So we're very careful about what we're putting on and how it's coming off. So when we're seeing these patients, we're trying not to make substitutions because it can affect sort of the ongoing management and perhaps further blister formation. Hidradenitis suppurativa is another one. This is sort of a painful long-term skin condition. It can happen anywhere from puberty all the way to adulthood. It's usually due to blocked hair follicles that causes abscesses and scarring on the skin. Again, depending on where it is, usually in the armpits, the groins, the buttocks, it can be difficult to adhere a dressing. And then also depending on the age of the patient, their hygiene, things like that can also affect their ability to cope with those types of wounds. Intertriginous dermatitis is an inflammation of condition of the skin folds, usually aggravated by heat, moisture, it's sort of skin-on-skin contact where airflow cannot get to, causing some skin breakdown. Usually it's worsened by infection, and commonly candida can be found in these areas. And our kids, with no fault of their own, sometimes they just have a lot of skin folds. They're sort of like head heavy, and then they're prone to keeping their neck down. And so they're not able to get the circulation in that area. So we sometimes treat with moisture wicking fabrics such as Interdry, antifungal powders, skin barrier wipes to help protect the skin integrity in these areas. You may see this more common in areas where there's more moisture risks, or for example, trach patients, immobile or complex care patients, or perhaps patients that are more obese and diaphoretic. And then lastly, we have a great plastic surgery team here. I should talk about incontinence-associated dermatitis. It's not something that we refer out, but it happens obviously a lot in pediatrics. An inflammation of the skin associated with exposure to urine or stool. A lot of our patients are diapered, but also there are populations that are more prone to it because of agents that we are giving them. So for example, patients on chemotherapy, where it may induce diarrhea with the therapy and then be caustic to the skin. Our goals are barrier protection. We will talk about a resource through the nurses specializing in ostomy continence care. There is a new pediatric IAD algorithm that's very useful and may be helpful to understanding management and what the specific barrier products that are suggested are. Typically, they're zinc-based, plus or minus antifungals, obviously if there's yeast, and using like cyanoacrylates, skin barrier sprays to protect the integrity and reduce friction with cleansing. In regard to plastic surgery, I'll just briefly talk about it. We do see a lot of burns here, grafts and donor sites. They are managed by our burn team. The goal is ideally to heal them within the first 3 weeks to reduce any scarring. We do use a lot of contact layers, nanocrystalline dressings, mesh gauze, things that are easy to remove and don't cause trauma with removal. And a lot of these things are left within for about 5 to 7 days to aid healing, and then are directed by the medical team regards to further management. So here's just a brief overview of the function of the skin. When we have good skin, what is it there for? Ideally, it's a physical barrier between the organism and the environment. It prevents invasion of pathogens, helps to regulate our body temperature, sensory perception, and provides UV protection. So how does that differ in pediatric skin? Okay, so pediatric skin, I'm trying to break it down in terms of age groups that might be helpful to understand the considerations that might put them at more risk if we're putting adhesives on them or dressings in terms of absorption. So let's look at our premature and term infants. They do have immature skin. They are at increased risk for infection. Their epidermis is loosely bonded to their dermis, which makes adhesive attachment very strong. So anything that is on the skin and needs to be removed could cause skin tears, blistering, medical adhesive related skin injuries. So we're very mindful of what we put on our preterm infants, ensuring that we're very careful on the removal of it, potentially using adhesive removers that won't be absorbed as well into the skin that could reduce the bond on that skin. Premature infants are at risk for transepidermal water loss. What is that? That's a loss of water and moisture from the skin that causes drying and peeling of their skin. So moisturization is important in this age group. And when the skin is dry, there's an increased inability to defend against irritants and bacteria, possibly increasing their risk of infection. Infants also have a large body surface area to weight ratio, which increases the risk for toxicity and absorption of topical agents. So things like alcohol and providine are usually cautioned in these age groups. Iodine dressings are usually not used in less than 6 months of age, are not recommended, especially for preterm infants, though they're at the greatest risk for hypothyroidism and iodine toxicity. So we want to avoid that at all costs if we can in this age group. Also in this age group, we notice that they have impaired thermoregulation, so they have a difficulty maintaining their heat and moisture. When a wound tissue loses moisture, there's a cooling effect on it, which can impair the healing and result in a lower wound temperature. So when we're putting products on the skin or on the wound, we're thinking about what's the temperature of that product. Is it very cold? How long has the wound been open? How long does it take to complete this dressing change? Because that can all affect the ability of that wound to recover to an optimal temperature and to aid that healing. In terms of infants and children, they start to get useful or helpful, I should say, in dressing removal. So they may attempt to remove them or contaminate them, touch them, scratch them. So what is the risk of a dressing is removed by the patient? What would it do to the wound? Will it cause trauma? So we need to find secure dressings to support their activity level and then prevent them from taking it off. Or something that is not traumatic on removal if they do. There's a lot of fear and anxiety in this age group that may complicate wound care. So they may not necessarily have pain, but they're fearful of the adhesive removal, or they have tape phobia. So we may look at some other comfort measures to help support their compliance and their ability to cope with that procedure. Other considerations, we look at the wound impact on day-to-day activities. So what is the location of the wound? Is there pain with it? What is the adherence of the dressing, and does it promote comfort? Ideally, comfort measures to support care would include things like distraction, play therapy, demonstration, putting a dressing on the client on another area, showing them how it comes off so that they can understand that it's hopefully not painful, providing adequate pain medication before the procedure and giving it time to work before we actually do the procedure is ideal, and providing psychological support of the parent and even for the parent, because a lot of parents are fearful of causing discomfort or pain in their child. So when we talk about wound management, it's actually no different than adults. We use this wound prevention and management cycle from Wounds Canada, which I think is very useful, helps us to understand how to assess and reassess wounds, establish goals, and implement the plan of care. So we will talk a bit about the implementation of a plan of care, cleansing, debriding, bacterial balance. Special consideration in regards to pediatrics are the causative factors may be different than adults because they have different comorbidities, their age, their size. What we can put on the patient may be limited because we don't have a lot of research for that. And then we have to think about their emotional state and their ability to cope with the wound that they do have. In terms of optimizing the local wound environment, we try and select appropriate dressings or cleansing agents that are not irritating, toxic, or painful, which we will discuss. In terms of debridement, we look at ways to support pain management and comfort of the patient. And then managing moisture balance and bacterial balance, we use appropriate dressings. We'll talk a bit about silver dressings and those that are widely used in pediatrics. And then as our community care partners and acute care partners, we really rely on your eyes in the community once they leave our doors to reevaluate the plans of care to make sure that they're still pertinent. And as the wound evolves, hopefully improving, that we can change that management, change the products. And of course, if something is not working, we're always open to having you communicate with us to see if anything needs to be reevaluated. Okay, so cleansing, what do we avoid in infants and children? So things like Dakin solution, betadine, hydrogen peroxide, they can impair wound healing, especially in our premature infants and our term infants. It can alter the pH, which does not aid for optimal wound healing, and then cause discomfort with application, so burning sensation, or perhaps affect the peri-wound skin. So what are our preferred cleansers? We like to keep it very simple, actually. Even burns and plastics, they do a lot of soap and water, just recognizing that it's fragrance-free, has no or low alcohol content, and normal saline. And then there's this hypochlorous acid solution, which is pH balanced, more friendlier to support this optimal wound environment. We've actually had really great success, and this is not a plug-in for the company, but we have had great success with hypochlorous acid solution, and finding that it is quite comfortable on application, very easy to use. A lot of the families enjoyed like sort of the soak method, instead of having to be vigorous with cleansing and movement. So I think that it is sort of it's been around for a long time, but I think for us, we're just seeing more and more benefits as we see more wounds. What we want to avoid is wet to dry dressings. I'm hoping that we're not seeing too many in the community, but I'm sure in adults it's a little bit different, but it's not widely used in children. It requires a lot of frequent dressing changes, increases the cost because it's likely going to be something that's going to be done daily. It delays healing by injuring new tissue. Dressing removal can potentially increase infection risk and cause more pain with dressing removal. So what are the types of debridements that we would support? I mean, our wounds are not typically very dirty. And we're usually kids are being taken care of by parents or caregivers. So, we're going to find these wounds probably earlier than later. So hopefully they're going to be a bit cleaner than some of the wounds that you may see in the adult population. And then our comorbidities of our patients are a little bit different. So they may not have outside factors that may contribute to the cleanliness of that wound. So we do support autolytic debridement because it uses the body's own enzymes for tissue removal. We find it's less traumatic, it reduces pain with dressing changes, and it reduces the frequency for daily dressing changes. It can be a little bit slow, but if you get it at the right time, it can help with new granulation tissue and provide selective debridement so that it's not pulling off that new tissue when you remove the dressing. What are some examples? So hydrogels, such as Intrasite, hydrocolloids, such as Duoderm. MediHoney is a great product, very safe for neonatal and pediatric use. Surfactant-based wound gels or hydrophilic wound dressings, such as Triad. And have a hierarchy of dressings as well that I'll share. That will also be on there. In terms of mechanical debridement, we were talking about cleansers earlier. So, when you use sort of the mechanical force of cleansing in combination with a cleanser, it can help to remove the tissue or debris from the wound. Having said that, it can cause bleeding, so we want to be very mindful about like what exactly are we using to provide that mechanical debridement. So you can use a spray wound cleanser, perhaps with a gauze, or there's these nice monofilament pads called Debrasofts that are used in dermatology because they're sort of soft. It looks like a mop, and it's very atraumatic to the wound bed. It doesn't necessarily cause bleeding, but you can use that in combination with one of those cleansers that I stated previously. But you do want to consider the pain from the pressure that it may be caused with mechanical debridement. So for example, if you're irrigating with the angiocath, you want to think about what that pressure may do to the wound and what the sensation may be with that type of debridement. And then thinking about cross-contamination from droplets when you're spraying, what happens to those droplets and where else can they travel and what could they potentially contaminate as well on other parts of the wound or other parts of the body. Here's a product considerations for pediatrics. Research is mostly adult-based. A lot of what we know is just based on what we've trialed. It's really difficult to know the absorption of creams and silvers in children when they're not tried. So we look at the ingredients and look to avoid possible irritants. Of course, children don't typically have these products applied to them, so we'll never really know. So we just trial the products and adapt it to pediatric use, looking at the literature, understanding the risks and benefits, and doing it under a controlled trial to see for any adverse reactions. When we're choosing the right dressing, we always say less is more, and I'm thinking this is also very common in community practice as well. We want to consider the frequency of our dressing changes to ensure that they're not ideally daily if possible. You want to promote something that have a dressing that's promoting comfort, reducing pain, maintaining that appropriate temperature in the wound and adequate pH, maintaining that moisture balance and infection and inflammation, promoting a healthy tissue edge, because without healthy edges, there's less potential for wound contracture or closure. You want to reduce risk of MARSI, which is medical adhesive-related skin injuries, or moisture-associated skin damage, skin stripping, maceration, looking to reduce the need for daily dressing changes, protecting the wound from friction and shear, and making sure that it is easy to remove. So what kind of dressings can we use? So basically, if it's dry, then you want to moisten it. If it's wet, then you want to take away that moisture, but ideally obtain that proper moisture balance. And then if it's deep, then you want to fill it. Okay, so here, this is just a general guideline, but I'm picking the ones that we would typically see here and that we would probably refer out to your community. Of course, there is a very large amount of wound care products out available, and what you may have on your formulary may not match ours, but hopefully you will fall into some of these categories and you can use your best judgment to pick something in that category that's similar to achieve the same result. So when we're looking at dry wounds, we're putting things to sort of retain moisture, heat, and provide autolytic debridement. Typically, the frequency of dressing changes for some of these are going to be anywhere from 3 to 7 days, but depends on the exudate level from the wound. A lot of these dressings are used for sort of low to moderately exudating wounds, and you have to be mindful about what might be coming out of the wound and how it may impact the peri-wound skin. So we've broken it down into these categories, such as transparent acrylics, such as Tegaderm, which are used for low exudating wounds. Sometimes they're, that's in there twice. Sometimes they're used for just protection of intact skin or newly epithelialized skin that don't have a lot of moisture. Hydrocolloids such as Duoderm are used for more like low exudating wounds. If you have a scab that you want to promote autolytic debridement, that's actually quite a good dressing to apply. You do want to observe the peri-wound skin for maceration, just protecting it, perhaps using a skin barrier wipe or spray around there to protect that. And then you want to caution it in neonatal use because of the strong bond of that adhesive over time. For non-adherent contact layers, I love these because they're very easy to remove. They do require secondary dressing though. They have low adhesion, use them for painful wounds, ones that are friable, that have issues with bleeding on removal. And there are antimicrobial options, which is nice. In terms of hydrogels, we talked about Intrasite. It's water-based content, so again, very safe for pediatric use. Use it for minimal or no exudate. You're wanting to add moisture to a wound or perhaps activate a dressing, such as Acticoat. We use that a lot to facilitate autolytic debridement. And again, you want to protect that peri-wound skin from maceration. Try not to get it on that intact skin because it may add too much moisture to that peri-wound skin. Hydrogel sheets are nice, like medical honey, Medi-Honey. There's some similar characteristics to hydrocolloids. There's adhesive and non-adhesive options. So you just may need to look at what you're using and see if there's a secondary dressing that's required. So now let's talk about wet wounds. We want to balance that moisture, and how do we do that? We're probably going to use a combination of these different types of dressings. We use Aquacel AG quite a bit in our infants, and we use them on moderate to highly exuding wounds. It does require a secondary dressing to fixate. It is used as a wound filler, comes in a ribbon and a gauze, can be cut to fit. So you don't want to use it in a dry wound or narrow deep sinuses where you can't pull it out, or dry wounds where it's going to possibly stick to the wound bed. But it's nice because it converts to sort of this gel. It's activated by moisture and it's very easy to remove, which is quite atraumatic. In terms of phones, we use a lot of Mepilex here. There's bordered, non-bordered. It's usually for low to moderately exudating wounds. It does wick the exudate into the foam and traps it in. There are antimicrobial options, which is great, and it allows you to visualize that exudate on the dressing. which is nice because you can sort of outline it. They've got this new flex that has the dots, so you can kind of see what percentage of the dressing is saturated. So it's sort of a nice visual cue. There's some calcium alginates. We have used calcistat here for moderately or highly exuding wounds. It does have a hemostatic capability, so it helps with sort of bleeding wounds. There is an antimicrobial option. And it is not contraindicated though for dry wounds, similar to the hydrofibers, because it can get stuck. And you don't want to use it for heavy uncontrolled bleeding. Hydrophilic dressings such as Triad are great because it conforms to an uneven wound bed, can stick to moist wounds or moist skin. We actually use it a lot in our incontinence-associated dermatitis or diaper rash. And it's a nice autolytic debrider as well. Nanocrystalline dressings are quite safe in pediatric use because it doesn't have a high donation of the silver. And it's used for moderately to high exuding wounds. You do need some moisture to activate the actual silver in the dressing, but it does require secondary dressing and is an antimicrobial choice. So what are some signs and symptoms of wound infection? This is just brief, but I just thought this was nice because it kind of gives you a little bit of how it may progress from a sort of a bacterial biofilm or bioburden into a systemic infection and what those signs and symptoms may be. So usually if you have 3 or more, then you're looking at a diagnosis of potential or actual wound infection. Antimicrobial dressings, we use them to decrease the bioburden of the wound, reduce inflammation. Sometimes when there's no progression in regular dressings, then we'll look to these to help kickstart it to a new phase of healing. It does penetrate into the soft tissues. And I'll discuss some of the ones that we have used here that we find are safe to use and easy to apply. One that is widely used in burns and also we use under negative pressure wound therapy is nanocrystalline silver or Actico Flex. It does have lower levels of silver, so there's decreased risk of toxicity. One key point is that you use sterile water instead of normal saline to avoid crystallization of that dressing. It may stain the peri wound, so we always let the families know that there may be a gray coloration that's left behind. But there have been some reports of stinging with application, and that may be depending on the inflammation that is in the wound. But some of our patients have said that they do feel it, but that does go away, dissipates after some time. Like I said, the silver is only activated if moisture is present, and it's nice because it's conformable. It can be used under negative pressure wound therapy. In terms of silver hydrofibers, we have Aquacel AG, which we just talked about. It's very well tolerated, easy conformable, good option for packing and easy to remove. There's also lots of silver foams now that are emerging. So Aquacel AG foam, for example, with a bordered or non-bordered options. And then Mepilex Mepilex AG has been around for quite a while. It has silicone backings, which is nice and easy to remove, and it's usually safe on intact skin. It doesn't cause any discomfort or discoloration. We like to use them around tubes, drains, pin sites because they can be sort of cut to fit and formed around those areas. And it's sort of a nice all-in-one dressing, so you're not having to put an Aquacel and then another foam dressing. It's nice that it's incorporated in one. Gentian violet methylene blue, such as Hydrophera blue. Actually, we have had great success with this dressing. So we have been using it in conjunction with the cleanser, with the Bosch cleanser that had the hypochlorous acid solution, and we've actually seen such great results. I just find that it's just easily well tolerated. There's no donation into the wound bed, so there's no risk for toxicity, and there's a lot of reported cases for use in neonatal use, which is great since we don't have that many. There are many different options, so bordered and non-bordered. It can be used under negative pressure wound therapy. And then there's also a ring for peristoma wounds when we have ulcerations around the stomas. Medical grade honey, again, lots of reports for neonatal and pediatric use. It's very easily tolerated. There are many different forms which can be applied, such as creams, gels, gauzes. It is antimicrobial and antibacterial. due to its pH, and it's a great debrider because it promotes this osmosis and helps pull out those devitalized tissue. Ones that we have used but are maybe not as well tolerated or has had some reports with stinging are PHMB. They come in disc, gauze, and foams, and then sodium chloride and salt. A lot of our patients will report stinging from the sodium chloride content in there. So we don't use it widely, but they can be used. And if this is something that is readily available in your area, that's fine. We would support that. Protecting the periwood skin. We really want to ensure that the skin is intact and that we're not causing trauma with the dressing application or dressing removal. So we're looking at things like adhesive removers and looking at no sting formulation. So ones without alcohol content so that it doesn't dry the skin and doesn't burn if the skin is not intact and used on there. We want to use cyanoacrylates to the periwound to reduce moisture-associated skin damage. So things like Kevlar, no sting barrier film or equivalents, and silicone adhesive removers such as nail tack, which I believe is called a Sentinel, or equivalent. Silicone foam dressings are always nice and our primary choice for secondary dressings to promote comfort, integrity, and aid for easy removal. I did want to touch upon negative pressure wound therapy. The indications for use of it are very similar to adults for exudate management, edema, and significant depth of the wound. The traditional vac is widely used here. It's great because you can adjust the pressure settings anywhere from 25 to 125, which is typical. You can cut the foam to the size that you need for that wound. It's typically used for mild to highly exuding wounds, can use for tunneled or deep wounds. There's different foams to use based on the different characteristics. There's the potential for installation therapy, but I hear that it can be difficult to source out in the community. Sometimes patients are waiting for a vac to be available. We do have to be mindful of protecting the periwound skin from maceration. And it can sometimes be difficult for family to troubleshoot how to stop a leak or how to seal it. And then our teenagers or some of our younger patients said the device is a little bit heavy to carry. So I did want to share that we are starting to use this portable negative pressure wound therapy or disposable ones such as the Pico. There's also an Avell out there. So if you do see that, we're always happy to have a discussion on, why we think this would be more optimal compared to the VAC. It is canisterless, so, you really just have to carry the device around, which is quite small, battery operated. It can support faster discharge home because we can just apply the dressing and not have to wait for any further supplies. It's very easy to use and apply, very similar to a silicone back dressing, and the dressing is the canister. It does have a certain capacity, which is usually 300, I'd say 300 mils, or a little bit more depending on the size. It can be used with antimicrobials and fillers, which is great, but of course, depending on the depth of the wound, that's going to limit whether you can use it. But there is a preset section of -75, so you don't have the option for adjusting that pressure based on the wound. But the best thing I find is you can shower with it on, and then it acts as a foam dressing if the suction is not maintained. So, where the vac is, we're worried if it's on for more than if it's off suction for more than 2 hours, we're worried about bacteria in the wound bed and maceration and things like that. This can stay on and just be like a regular dressing if the suction is not maintained in that device. We are supporting it and we feel that it is just a great option when vac therapy is too complicated or just not available. what does our discharge planning look like from here? We usually make a referral out to the community care partners and we send supplies for the first dressing change. We like to demonstrate the dressing application in case there's any delays in perhaps you being able to see the client in their home. And we'll usually indicate when the dressing was changed so that you know how many days before the next dressing change. The family are always encouraged to email photos to our teams. Just gives us another eye on it to know whether we need to reevaluate or bring them in. Weekly photos and measurements are ideal in your own practice, and it's something that we support with the families as well. And follow-up is not always done here. We don't have a wound care clinic per se, but it may be done with the specific team that was referring them. Or if a reassessment is required, we're always happy to bring them back. We do appreciate calls if there is no progression, worsening, or concerns about our current management plan, because that may change. And we do ask that families go to emergency if they see two or more of the following, such as purulence, fever, bleeding, increased pain, increasing redness. If you notice that in your assessments as well, we're always happy to get a phone call or an email just to let us know that the characteristics may change and they may require further management. When to contact your case provider, again, worsening of wound care status if the products ordered are not available, not on your formulary, not available for special order. If they are very specific and they're hard to source, please let us know so we can look at different options. More general advice in pediatric wound care. I mean, we do get a lot of calls just for sort of general support. So we're always happy to troubleshoot together. And we are actually looking at a community care practice that we're trying to develop. So if anybody is interested in that, please reach out to us as well. Here are some wound care resources that are available through Sick Kids, but also externally through Wounds Canada or the NSWOC. There's a lot of best practice recommendations out there to guide practice for wound care. So definitely have a look. We will actually put these all out in our Connected Care. It's the Connected Care Hub, I believe. So these links will be available, but they'll also be in the PowerPoint, which will be available on that site as well. So have a look at those. And then, yeah, I think we'll have time for some questions, and I'll take a look at the chat here to see what you've put in there, and hopefully that was helpful to you all. I appreciate your time today, and I look forward to having some time to chat after all this. Okay, so let's see here in the chat. I have something. How do you choose which antimicrobial to use? So that's going to be dependent on the type of the exudate level. So when we're looking at that chart, we're going to sort of see what is the exudate level, maybe even the chronicity of the wound, because what is the agent that we're going to be using, right? Is it going to be silver? Is it going to be betadine, iodine? Or chlorhexidine, as you're listing here. That's going to be dependent on the size of the patient and the age of the patient and the wound characteristics. Really, I don't necessarily one is favorable over the other, but for us, we're looking at sort of what's the ease of application and what's the ease of removal, and what is the absorption level of that dressing. So that's what guides us in terms of choosing those types of antimicrobials. So for us, that would likely be, more of the hydrofiber dressings or the Eptocoat dressings. Are silver dressings other than Eptocoat safe for kids? Silver cell, yeah, that's an applicable hydrofiber. And Exalt, Medline silver foam. Yeah, those are all fall under the same categories. Yeah, Eptocoat doesn't necessarily. I mean, it's a nanocrystalline. I don't know that there are other ones out there. Correct me if I'm wrong, if anybody's heard. If there are any other nanocrystalline dressings out there, but I think that's the only one. So, when that's not an option, I think that what we do have in regards to other silver dressings is applicable. I think you're just looking at sort of what's the characteristics of that wound and the conformability, what the indication of use is. We do use it a lot of in burns and plastics, but that doesn't mean that was the be all that ends all, because we actually used to use Aquacel prior to Acticoat being around. So that doesn't mean that we can't revert back to one of those. I think we just have to look at the adhesion and the ability to remove from the wound, which is nice that we have these new sort of contact layers or low adhesion dressings as another option with antimicrobials in them. I see Samantha said, most common in our practice is burns, frequently with orders with flamazine and gauze daily, and pain is the biggest challenge. Yes. So there are some contraindications to sort of flamazine and being used. We actually do use them for our omphalocele as well. In the beginning phase, it's a great antimicrobial defense, but we do worry about the absorption of that over time. I think you have to look at the duration of when you're using antimicrobials as well, because typically you should be using it for at least 2 weeks and then see how that responds before we say that it's not working. In regards to daily dressing changes, I mean, I think if there are other options out there, so if that is something that is still common in your practice, I mean, I think it would be a good discussion to have with our burn experts here. So if you'd like to connect with them, please reach out through our email. And then hopefully we can help to see whether we're at, that's the best practice. What else do we got here? What can we best recommend for incontinence associated dermatitis? So I would recommend that you go on to the resource page that we put out, because the nurses specializing in wound ostomy continuity care put out a pediatric IAD best practice recommendation, and that go through all the different agents that we would use for the different degrees of IAD. Because it really depends on the severity. So whether it's sort of superficial or ulcerated, whether it's infected, we're going to look at those different characteristics to guide our management. But typically what we use here is a 25% zinc, and then we sort of upgrade to 40% zinc when things are not not improving. And we actually mix that with stoma powder. So it's sort of like a zinc oxide powder in a bottle. And we use that to fortify the zinc oxide to make it stronger and thicker. Because basically what you want to do is make sort of impenetrable force for the stool or urine to get through. And then actually the best recommendation that you can make is reducing friction on the skin. So your cleansing is very important, making sure that we clean the skin once a day, let it open to air, and then apply the products. And then when we're cleaning and stooling or urinating, that we're not rubbing all of that cream off. We want to use it as a barrier. So we're only taking off the cream that is soiled and leaving all the intact cream in place so that the friction on that impaired skin is reduced. Hopefully that was helpful. And then are there any age restrictions for any of the antimicrobials? No, honestly, there's nothing that the manufacturer has given us because there's no studies to guide that. So unfortunately, no, but I think when we look at the ones that we've listed, the way that I had listed it and sort of like nanocrystallines, gentian violets, like I put in the order of how we would typically progress in our silver-based decision making. We would want to avoid the ones where there have been obviously reports with burning or stinging. I'm not going to go towards those first. I'm going to use the ones that sort of are much more tolerable. Can you repost the email on the last slide? Yeah, sure. I'm actually going to just leave it in the chat here so that you can.
Oh, I just added it into the chat.
Did you? Oh, you just did it. Oh, look at you.
Yeah.
So fast. Look at you. Thank you, Stephanie.
Along with the best practice recommendation that you just mentioned.
Great. Yeah. So that's the link for the IAT. And then what are common challenges? Another common challenge is when you are working with clinicians who are not receptive to feedback or changes to the recommendations. I mean, I think this happens everywhere. I feel like as long as we have the common goal in promoting the best outcomes for the patient, I mean, that should obviously guide our practice. Having said that, there may still be ancient practice out there too, where clinicians are not open to advances in wound care practice as well. I mean, I would encourage them always to, send these links out, have them join these webinars, really understand what's new and upcoming, or has been actually for a while. I wouldn't say this is all new, but, moist wound healing versus wet to dry, I mean, it's still an issue, and we still sometimes see it even here. So, just having open discussions about what our goals are for therapy and what the best would be for the patient in terms of comfort and care is really all you need to do. But I agree, it's always a common challenge, I think, no matter what area you work in. So that's why I think I'd love to develop this community care practice and really bounce ideas off of each other and understand what you're seeing in the community so that we can understand if what we're even suggesting is applicable or if it's doable, and then how we can help support you if it isn't. Yeah, and I think there's one more question about zinc. You use zinc stoma powder mixture on a severe perianal breakdown. It worked great with quick bum soaks when cleansing was required. Yes, actually, one of the newest innovations, I guess innovations, but we learned from a hospital in Texas, Children's Hospital in Texas, is using Bosch hypochlorous acid solution on the buttocks when it's quite ulcerated as a comfort measure. So soaking the bum, so you can still do your daily bath in soap and water, and then soaking the bum with a gauze or a cloth soaked in Bosch for about 5 to 10 minutes is actually quite calming, and you can see them become less irritable over time as that comes into play. It has sort of a cooling effect and a comfort measure in it. So using that combined with all the zinc and barrier creams actually has helped to accelerate some of the healing in these types of wounds. Having said that, you always have to address the cause. So if they're having diarrhea and they're constantly having diarrhea, you can't expect that this is going to necessarily magically resolve without that cause being treated. So understanding what the accelerating factors are for that is very important. Does anyone else have any other questions that they want to share, or experiences that they want to share?
There's just a question about the wound care community of practice that you want to start. And so I think it's not yet started yet, but it's an idea that
it's
Christina and Cindy have.
I'm hoping that by you asking that it's a good idea. But really what we're trying to do is connect community care partners to understand, so we can sort of standardize practice, especially specifically for our pediatric patients, so that when they come from our hospital to yours, it's not necessarily markedly different, or that it's consistent, so that our wounds can hopefully have a better trajectory for healing. If we're changing management all the time, I know it's hard because you have restrictions in formularies or what's available to you. So if we can at least just talk about what those restrictions might mean and how we can best tailor around those, that's all we're really trying to do with that. So yeah, if you are interested, email that wound.ostomy@sickkids.ca, and then we'll see sort of how many members we get and kind of go from there. But we appreciate your interest.